This conference will now be recorded.
Hello. There are four people. I am Dr. Parul. I am your mentor today, and we'll be discussing about the new talk regarding the management of urogynecological problems in pregnancy and the postpartum period. There are a few changes in this talk as compared to the previous guidelines, so we'll be emphasizing on the same. It is an interactive session, and I really need you people to participate wholeheartedly. It is equally important for part 2 as well as for part 3. So, those candidates who are appearing for either of the exam, they will be benefited. I will be asking a few questions in this session before beginning the theory part. And let's see who all can answer these questions now and what will be the answers once the session is over. So first one is this on your screen. I hope all of you can see. Which is the commonest type of urinary incontinence during pregnancy?
SUI, ma'am.
Correct.
Yes, you
Correct. Next one. What is the first line treatment for SUI in postpartum period?
T.
Which one?
PFMT.
B.
Muscle
Pelvic
training,
floor
ma'am.
muscle training. Yeah, PFMT is pelvic floor muscle training. And what is the first line treatment for overactive bladder in pregnancy and postpartum period?
Fluid management.
Oxybutynin.
Yes. No, it's basically lifestyle management. Lifestyle changes. Yeah, we will discuss about it later. And
Okay,
fluid
ma'am.
management is the answer here. So
Fluid
let's
management.
start with this thing. I will be discussing stress urinary incontinence, urge incontinence, overactive bladder, recurrent UTIs, prolapse, and post-delivery urinary retention today. So as someone said correctly, that SUI is the commonest type of urinary incontinence during pregnancy, with prevalence ranging from 19 to 75%. See, these are some very important points. Like if you remember these percentages, these are helpful in part 2 as well as part 3, that what is the incidence and prevalence of things. So SUI is the commonest during pregnancy and it increases with gestational age. But the important point is that the mode of delivery can affect whether SUI will resolve postpartum or not. This is a point. And can anyone tell me what do we understand by stress urinary incontinence? Anyone who is appearing for part 3? So stress urinary
So
incontinence.
there is a
Yeah.
there is a leak of urine when there is an
Hmm.
intra-abdominal pressure is increased, like coughing or lifting weight. When the urethra becomes straight and the angulation between the urethra and the bladder becomes straight, ma'am.
Very
The
good.
angle is
Very well
lost.
answered. Yeah, correct. So it is an involuntary loss of urine on effort or physical exertion or on sneezing or coughing. And as you correctly said, the angle, there is a problem with the angle. So pelvic floor muscle weakness causes urethral sphincter incompetence owing to increased mobility of the bladder neck and urethra. And this talk states that vaginal delivery increases long-term SUI by 8% as compared with cesarean section. So if someone asks you whether the mode of delivery will affect the incidence, then yes, the mode of delivery can affect the incidence of SUI. Then there was a question, what is urinary microbiome? Anyone has any idea about urinary microbiome? This carries an importance during pregnancy and postpartum. because they say that there are these three bacteria, Lactobacillus group, Gardnerella, and Streptococcus, which are generally found in vagina in presence of estrogen. But because as we know that pregnancy and postpartum, there is a like lack of estrogen, it is a high progesterogenic state. So in that case, if these bacteria are absent, then there are high chances of recurrent UTI. So urinary microbiome refers to the bacteria present in the urine with no clinical infection. And three groups of bacteria, Lactobacillus, Gardnerella, and Streptococcus, constitute urinary microbiome. One more question for you people. What is the antibiotic prophylaxis of choice in recurrent UTI in pregnancy?
Florentine, ma'am.
Which one?
Ma'am.
Out of these three, which is the antibiotic prophylaxis of choice?
Trimethoprim, ma'am.
Trimethoprim. I'll be discussing it later, that what all which can be given in first trimester and which can be given in the last trimester. So now we will start off with some of the physiological changes that occur during pregnancy. Most of them are generally we know in our after reading for part 1, but I will be reading only the effects, like what effects will be there in physiological changes in pregnancy. Increased urinary frequency, increased risk of urinary infection, and urinary incontinence and retention. But the only important physiological change which we need to remember is that increased cardiac output causes 50 to 60% increase in the renal blood flow. This is an SBA which is regularly asked, that what is the percentage of increase in the renal blood flow during pregnancy. So it is 50 to 60%. This was the earlier table showed changes during pregnancy. Now changes during puerperium. As we can see that most of the changes lead to urinary retention. So postpartum urinary retention is a very important topic regarding our both part 2 and part 3. And what are the common causes of urinary retention? The bladder wall becomes edematous, hyperemic, and compression of urethra by this edema and hematoma may lead to urinary retention. Reduced bladder tone and bladder sensation, and reflex inhibition of micturition caused by genitourinary trauma. These three things we need to remember whenever we need to explain to the patient the cause of urinary retention in part 3 as well as if questions in part 2. So as we were talking about stress urinary incontinence, we had already discussed about the definition, and that it is the most common type of incontinence found during pregnancy and this puerperium period. Surgical treatment is usually not considered in SUI until the woman's family is complete. And if a woman wishes to become pregnant following incontinence surgery, the risk of future surgical failure ought to be discussed. As we know that the MASH surgery is no longer being recommended for SUI. So if the patient has already undergone any sort of surgery for incontinence like colposuspension or any other surgery for prolapse, nowadays it is no more advocated that every time a cesarean section has to be performed. The pros and cons has to be discussed with the patient. So the mode of delivery does not appear to affect SUI recurrence following surgery. Any questions in SUI? You people want to ask any question? SUI in pregnancy and postpartum period. These are all the most of the important things that I have covered in this new talk, which they have changed or there is something new regarding this. So now comes overactive bladder. What is overactive bladder? Overactive bladder is characterized by symptoms of urgency with or without urinary urgency incontinence, as well as frequency and nocturia in the absence of any obvious pathology such as urinary tract infection. Up to 41% of the pregnant women experience micturition frequency, which commonly starts in the first trimester. See, again, there is a percentage. So what is the incidence? Earlier it was more, now it is only 41%. What are the causes that they say that causes overactive bladder? Anyone? The bladder capacity generally reduces during pregnancy, and so there are urgency and patient has frequency to go to the washroom. What can we do? Like what all things are there?
Bladder retraining,
Yes. So first of all, the most important primary thing is lifestyle modifications.
modification, right?
Lifestyle modifications consists of modifying fluid intake, like we stop giving fluids after 6 p.m. in the evening, and reducing the total type of caffeine and total citrus fruits and citrus juices, and pelvic floor exercise and bladder retraining, as you correctly said. So always the first line of treatment would be conservative and lifestyle modifications. In cases of SUI, it is supervised pelvic floor muscle training. If there are two options, then the supervised pelvic floor muscle training is always the right answer. And then this, in these cases, lifestyle modifications, the four things that are important is modifying the fluid intake, reducing or stopping caffeine intake, pelvic floor exercises, and bladder retraining. I hope I am clear so far. Then there come the anticholinergic medications. Anticholinergic medications, they are specifically oxybutynin. Oxybutynin is offered during pregnancy and breastfeeding. So if they go for drugs, then the drug of choice during pregnancy and postpartum period in case of overactive bladder is oxybutynin. Then there are these some of the modalities. The two major modalities were lifestyle modifications and oxybutynin for overactive bladder. And then these comes, they have given these things which you may remember, but they are not the first line. Like intravaginal estrogens. Intravaginal estrogens do have a role. Low dose local vaginal estrogens can be used postnatally to treat overactive bladder symptoms in breastfeeding, owing to the reduction in endogenous estrogen level. And then intravesical botulinum toxin. As we know that it is used in non-pregnant patient, and it is generally not offered during pregnancy and postpartum. And both of these nerve stimulations, they are not offered during pregnancy and postpartum period. So if a question arises during pregnancy, overactive bladder, then lifestyle modifications and oxybutynin. We go only for these two things. We can use intravaginal estrogens, but botulinum toxin and these nerve stimulations are no. Then we come to pelvic organ prolapse. In general, what do we understand by pelvic organ prolapse? Pelvic organ prolapse refers to the loss of the support for the uterus, rectum, colon, or bladder, leading to the organ's descent into or out of the vagina. I hope every one of us is well versed with what is pelvic organ prolapse and what is POPQ classification. So the question may arise that what all are the risk factors for developing prolapse later in the life? Most important is difficult vaginal delivery. Given an option of all the four options, if there is an option of difficult vaginal delivery, then we'll have to take that for, like, in future, pelvic organ prolapse is most likely to develop following a difficult vaginal delivery. And other factors include forceps delivery, prolonged second stage of labor, LGA baby, and third and fourth degree perineal tears. And as we know that if we have encountered a pelvic organ prolapse during pregnancy, so the mainstay of treatment will be same: lifestyle management, diet and exercise, and if not controlled, then vaginal pessaries. We generally don't go for surgeries during pregnancy and postpartum period. Now comes the recurrent urinary tract infection. What is the difference in urinary tract infection, the presentation in pregnant and non-pregnant patient? Generally, there is no difference. The symptoms are the same. They include dysuria, urinary frequency, and urgency. And the importance is that for what test should we go? The first line of test is always the dipstick infection. It has got specific role. We were talking about urinary dipstick. Initially, we always start with urinary dipstick. Urinary dipstick is the easiest test available and it is always the first screening test. Remember, if the question asks that which is the first screening test, then urinary dipstick, in which we will find whether the how they find about the amount of nitrates. But there are some bacteria which actually do not convert these nitrates to nitrites, specifically gram positive like staphylococcus and enterococci. So for such organisms, we need to go for culture. So whenever a question arises, what is the screening test? Then it is always the dipstick. But confirmatory test is always urine culture. Urine culture, the colony count should be more than 10 raised to power 5. That is 5 zeros after 1. These are some of the important figures that could be asked anytime. So a pregnant lady has generally goes for a culture one time during the antenatal time to see for asymptomatic bacteriuria. What do we understand by asymptomatic bacteriuria? Where the patient generally does not present with any symptom, but there is continuous bacteriuria and it can result in complications. So a UTI during pregnancy can result in complications such as, anyone, what all complications can we encounter with UTI during pregnancy?
Preterm labor, ma'am.
Yes, preterm labor, very good. Most common is preterm labor. Second one?
Pyelonephritis.
Yes. Preterm labor, pyelonephritis, stillbirth, chorioamnionitis, as well as small for gestational age babies. I must say that you all are very learned pupils. So now we come for recurrent urinary tract infection. How do we define RUTI? In non-pregnant patient, there are 3 episodes of UTI in the past 12 months or 2 episodes in the last 6 months. However, there are varying definitions in pregnant women. To make a diagnosis of RUTI, there must be a positive urine culture in association with lower urinary tract symptoms. Coming to the question that we were discussing in the starting, what is the prophylaxis guidelines as per NICE? So the NICE says that these two are the drugs of choice for prophylaxis, trimethoprim and nitrofurantoin. But trimethoprim has to be avoided in first trimester. Can anyone tell me what is the reason behind it?
This folic acid will not be acting, ma'am.
Yes, so trimethoprim interferes with the folic acid levels and that's why we avoid it in the first trimester. And why do we avoid nitrofurantoin in the last trimester?
It causes G6PD deficiency, ma'am. If G6PD
Yes.
deficiency, it can cause, yeah,
Hemolysis, right? Very good. So
hemolysis.
this has to be remembered, and these questions are like these are recall sort of things. Trimethoprim is to be avoided in the first trimester, and nitrofurantoin is to be avoided in the last trimester. And then amoxicillin and cephalexin are the second line drugs according to the NICE guidelines. There are no specific guidelines to retest after a positive urine culture. But a repeat urinary culture is in practice and is usually sent after the completion of a course of antibiotics to ensure that the infection has been adequately treated. And for those patients who are having RUTI, testing has to be done fortnightly until 36 weeks and then weekly until delivery. And this is the Cochrane review that if the patient is already a known case of RUTI, then every fortnightly you will do urinary culture till 36 weeks and after that weekly it should be done. So in recurrent urinary tract infections, these 2 or 3 things are very important, like the drug of choice and what is the frequency of sending the urine culture. And then there was something about urinary microbiome that I have already discussed, and those 3 bacteria were Lactobacillus, Gardnerella, and Streptococcus. So how do we, apart from antibiotics, prevention of UTI in pregnancy is another important topic. So what all we can use? These are some of the things which they say that have a role. See, in which hygienic behavior, obviously, and ascorbic acid, they say this appears to be beneficial. Kenephrone, which consists of rosemary, lavage, and centaury. Methamin hipurite, this is some antiseptic, and D-mannose is a sugar which prevents bacterial adherence. So these are all, if you get an SBA that all of the following may have a role except. So in that case, they say that there is no evidence that cranberry consumption reduces the incidence of UTI. As the marketing, nowadays it is highly marketed that cranberry juice is very effective. But according to the newer this talk, cranberry juice has no role in decreasing the incidence of UTI. Now we come to urinary retention during pregnancy. According to the recalls, if we see, then urinary retention during pregnancy, how do we diagnose and manage? It is the most important topic in this talk, which is very often and frequently asked both in part 2 and part 3. So as I have already told that there are what physiological changes which lead to this retention. So we can understand that the physiological changes are such that if these changes wean off, then urinary retention will be resolved on its own. So what is postpartum urinary retention? It is a common condition after childbirth with a prevalence ranging from 14 to 24%. This is important and it has been asked a few times. What is the prevalence of PUR after childbirth? So it could be from 14 to 24%. Now what is overt PUR and covert PUR? Anyone has any idea about this?
Overt means it is expressment. Covered means we have to find out. It is there, but is it? Am
Very
I right,
nice.
ma'am?
Yes, absolutely right. According to the word, the definition, you are perfectly right. Overt means that the patient is just not able to pass urine within 6 hours of vaginal delivery. But it was earlier that it was advocated that 6 hours. The new talk says that we have to encourage the patient to pass urine within 4 hours of vaginal delivery or removal of catheter. But if the patient is not able to pass within 4 hours, then a grace time of 2 hours is to be given to the patient. Then it becomes 6 hours. So this we have to keep in mind that it has been changed to 4 hours from 6 hours according to this new talk. And then covert PUR. Covert PUR is where the patient passes urine. There is a spontaneous micturition, but the residual post-void residual volume of the urine is greater than or equal to 150 ml. So how do we find it? We can find it either by an in and out catheter or by a bladder ultrasound scan. The exact cause of PUR is unclear, but is probably multifactorial. So what all risk factors are there? Epidural analgesia, prolonged first or second stage of labor, instrumental delivery, episiotomy, primiparous patient, and physiological changes as we have already discussed. This is just this is just a point that I wanted to say that I will go through this so that if there is any question like all of these can lead to PUR except, then in that case we should be knowing that epidural analgesia, prolonged first or second stage of labor, instrumental delivery, episiotomy or primiparous patient. Primiparity is important. Now, how do we talk to the patient regarding whether she is having PUR or not? There is something called as VESI, which they have advocated in this talk only. And this is particularly important for those who wish to appear for part 3. That if you are getting a patient and she is complaining like, I'm not able to pass urine, or even after passing urine I feel that my bladder is not empty. So this is the history questions of history taking that they have emphasized. VESI. VESI means V for volume, E for empty, S for sensation, S for stream, and I for incontinence. So we need to remember that did you pass a good volume of urine? Did you feel that the bladder was empty at the end? Do you have a sensation that you still want to pass urine? Was your stream normal? And was there any incontinence? These 5 things we need to cover in the history. Like, what is the volume of urine voided? Was it empty at the end? Do you have a sensation to pass the urine? Or do you just don't have any sensation at the end there is overflow incontinence? And was the stream normal? So this VESI we need to take care of according to this TOG. This chart is a bit changed chart as compared to the earlier one. This time they have made more than 3 categories. So let us go point by point. As I already emphasized that this time it is 4 hours. So encourage women to void within 4 hours of catheter removal, and a further 2 hours can be given, totaling 6 hours. And you should document the voided volume. Now there will be 2 things. Either it would be an overt PUR or a covert PUR. Overt PUR means that there is no unable to void. Like the patient will say that I just was not able to void the urine. Then in that case, we will assess that how much urine is there inside the bladder. It could be done by in and out catheter or by an ultrasound scan. And there could be possibilities. As I told that this time they have made 4 categories: less than 150 ml, 150 to 250 ml, 250 to 700 ml, and more than 700 ml. So what all actions we have to be taken? In cases if it is less than 150 ml, then in cases of 150 ml, we need to consider the causes of reduced urine output. Like the urine formation is less, then it is not a case of retention, it is a cause of oliguria. So the whole case shifts towards oliguria. And what could be the causes of oliguria? Can anyone tell me what could be the causes of oliguria in postpartum state that we can think of?
Any bleeding or any
Dehydration,
dehydration.
hemorrhage.
Patient has not
Yes.
taken adequate fluids.
Yes, very good. And one more important thing that is left.
Hyponatremia, ma'am, because of oxytocin, fluid
Yes,
retention.
hyponatremia and sometimes in cases of abruptio placenta, there is acute renal shutdown also.
Yes, ma'am.
So these are all the things that we need to rule out in that case if the residual urine was less than 150 ml. If it is 150 to 250 ml, then we have already done an in and out catheter. So we will ask the patient for one more attempt, like proceed attempt at second void at 6 hours post catheter removal. So we will do this whole flow chart again if it is 150 to 250 ml. But if the patient is having that residual urine between 250 to 700 ml, then in that case we will have to insert an indwelling catheter and we will remove the catheter after 24 hours. See, there are 4 categories. If less than 150 ml, then go towards oliguria. If 150 to 250 ml, then go to the starting of the flowchart again and then try voiding again. And if it is 250 to 700, then put a Foley's catheter and just take out the Foley's catheter after 24 hours. And this TWOC means trial without catheter. So trial without catheter after 24 hours. And then if it was more than 700 ml in the starting, then put the catheter, send the patient home and call her back after 2 weeks for the catheter removal. So this flow chart, this right side of the flow chart is for overt PUR. Now we come for covert PUR. Covert PUR can also come as overflow incontinence. So the whole thing applies to that also. In cases of voided, we will ask VESI. See, there they are mentioning VESI suggests retention. So now if retention, you feel that there is retention, yes or no. If you feel that there is no retention, then a second void at 6 hours post catheter removal, and then an in and out catheter assessment. This whole flow chart is important from your EMQ point of view also, because they will give you multiple scenarios that this much was the urine and this much was the urine, what will be your action. And if the VESI suggests that there was a retention, then you do the residual assessment. And now there are only 3 criteria here: less than 250 ml, 250 to 700 ml, and more than 700 ml. So if it was less than 250 ml in case of covert, then proceed for second void at 6 hours. In the retention case, it was less than 150 and 150 to 250, but here less than 250. And in case of 250 to 700, then the same thing, put the catheter and remove it after 24 hours. And in the case of more than 700, then put the catheter and removal after 2 weeks. So I'm just emphasizing again and again that just look, it is less than 250, 250 to 700, and more than 700. Now, in case where the VESI was not suggesting retention and we went for an in and out catheter assessment, then in that case also, if it was more than 700 ml, then we will go for a catheterization and send the patient home and call her back after 2 weeks. And if it was 150 to 700, then catheter and removal after 24 hours. And if it was less than 150 ml, then we will label it as a successful trial without catheter. So does anyone have any question regarding this flow chart? Because this flow chart is very important. Okay, so if I give some question regarding this flow chart, would you people like to attempt?
Ma'am.
So you are in a postnatal ward, and you are talking to this patient who had a normal delivery yesterday, and she says that after urinating also, she feels that the bladder is not empty. Then what would be your first step in the management?
We have to measure the residual urine, ma'am, by in and out catheter.
Very good. And after measuring the post-void residual volume, you find out that the residual volume was around 500 ml. Then what would be your plan of action now?
Then we have to keep it for 1 day, 24 hours, and then again try for without catheter, trial of urination without catheter, ma'am, after 24 hours. Am I right, ma'am?
Very. Yeah, absolutely. So I hope you got the thing that what does this chart want to say and how will we proceed regarding this case scenarios. These are all new things. The main things which these people have changed in the new talk, I have already mentioned. And the new thing was that the time is changed from 6 hours to 4 hours. There is something called as VESI's thing, which we need to ask to the patient regarding retention. And then the criteria has changed from less than 150 ml, 150 to 250, 250 to 700, and more than 700. These are all the important points to remember, and this urinary microbiome, which is new in this talk. Anything that you people want to ask, I am happy, and I really want to answer your questions. And if not, then this is all for today's class.
Hello, ma'am.
Yes.
You said that for recurrent urinary tract infection, we have to do urine culture fortnightly till 36 weeks, and after that weekly. So the weekly for how many days?
Till delivery?
Till delivery, okay.
Yes. If you feel any question that you forgot to ask during the session, you may put up the same thing in the free group, and I'll be answering your questions. Thank you for attending today's class.
Ma'am,
Very,
so
very nice.
small but very crisp. Thank you, ma'am.
Yeah.
Chalo, that's good that you people liked the class, and we will be repeating such small talks. Actually, these are small talks, but they are very important. Small things which we need to remember, and we will be doing the revision time and again, and hopefully all of you will succeed in your exam.
Thank you, ma'am.
What is the question
Thank you,
asked,
ma'am.
Shaz? Put the right.
Anyone wants to ask anything?
Yes, there's something in the inbox, chat box. There's some question.
I'll see.
Repeat starting SUI. What do you mean, Dr. Shazia? If you can just unmute your mic and tell us, because I'm not sure what is the question. Dr. Parul, can you understand what the question is about?
I think she missed the starting, huh? That is what I felt.
Okay. Okay. Yeah, we'll put up the video again for those who could not join in time. And please tell us what is another topic, hot topic that you want, because we are happy to help people, and we can have these sessions over and over again so that all your doubts will be clear. We can have more of SBAs and more of EMQ on topics like this. So please tell us which topics you want. You can put it in the group, or you can tell us right now also. We'll be very happy to conduct more sessions in the recent times, like before your exams. We understand that the people going for the January exam, and this is a high time to read the new talks. So you can tell us the topics, and we'll make sure that you finish it within time. So 15-20 minutes, we can revise all the important talks. Isn't it, Dr. Parul? I think that is a good idea. What do you think?
Yes, I'll be there, and of course, our team of mentors are there, and we are really happy to help them.
Yeah. Is there any topic that comes to your mind? Anyone in this group? Because everyone who have joined this, I think they can keep up with us, and please join the free Telegram groups so that you keep on knowing whenever there is a free session, and we'll try and hold more free sessions more frequently now hereafter. Because exams are coming.
We can practice some
Sorry.
recalls also if you people want to discuss any recalls or anything that you feel is difficult.
Yes. Yes, Doctor, you want to speak something? There's one person who is okay. So I think that is the end of the
Ma'am,
session. I think that was a very good session.
yeah, ma'am.
Yes.
One thing, if you can take another class regarding CTG, some CTG issues, some recalls
Sure.
or some exercise regarding the CTG, that will be helpful. Another thing is
Yeah.
regarding the cervical screening, so that will be also
Yes.
helpful. And it's a cervical
Yeah.
screening program.
Yeah.
Sure.
And
Thank you, ma'am. Thank you so much for your nice class.
yeah. I understand that both the topics are very, they are very confusing. They are very lengthy, and yeah, you need to keep on revising both of them. So I understand that, and yes, we'll keep it uh, in the recent times only, like mostly in the next week. So we'll try and prepare this. Thank you for your suggestion.
Thank you so much, ma'am.
Thank you all
Okay,
for
bye.
your feedback also. Yeah.
Okay then. Thank you, Dr. Parul. Goodbye and good night from me and Dr. Parul as well. So we'll end this session. Please be active in the group so that we can all, in the last 1 month is a very important month, and we can all study together and make it in this January only. Right?
Yes, ma'am.
Thank you so much, ma'am.
Okay. Good night, everyone.
Good night.